Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of we are discussing autosomal dominant polycystic kidney disease ADPKD. This is ADPKD, autosomal dominant. So by definition, it is systemic hereditary disorder characterized by bilateral renal cyst formation, extrarenal involvement, and most cases are adult onset. So basically this is a kidney disease, but it is not limited to kidney. It is having many extrarenal manifestations, and it generally presents in adult and runs in family. So this is brief description of autosomal dominant polycystic kidney disease. Okay, so what is the epidemiology? Just remember this autosomal dominant polycystic kidney disease is the most common hereditary kidney disease. So which kidney disease is most common hereditary disease in overall population, that is ADPKD. So autosomal dominant inheritance but with high penetrance. So this is very much important. This is high penetrance disease. De novo mutation occurs in 8 to 10% of cases. So what are the systems are involved? Kidney is obviously involved. That's why it is named like that. So cyst formation leading to chronic kidney disease and leading to end stage kidney disease. In liver, hepatic cyst. Liver is the most common extrarenal manifestation of autosomal dominant polycystic kidney disease. Pancreas and spleen cyst may develop, but they are usually asymptomatic. Brain, just remember a very important thing, risk of intracranial aneurysm is 15%. So if there any family history of aneurysm is there, then you have to screen those individuals in that family at 18 years of age with magnetic resonance angiography. So this is significance lies here. Heart, mitral valve prolapse, aortic aneurysm, coronary artery aneurysm are seen in 12%. So routine echocardiography is advisable. Other findings like hernia, bronchiectasis, and intestinal diverticulosis are also seen. So this is important consideration. Okay, so how this disease presents? So just remember, in renal finding, bilateral enlarged kidney similar to autosomal recessive polycystic kidney disease with cortical and medullary cyst. With cortical and medullary cyst. So in pathology of autosomal dominant polycystic kidney disease, bilateral large kidneys with cortical and medullary cysts are seen. Basically, these cysts are large. So, cyst arises from all nephron segment. This is very much important. Progressive tubular dilatation and interstitial fibrosis is seen. So, this is actually large cyst and no corticomedullary differentiation is lost. What are the extra-renal cysts which are there? So as we discussed, also hepatic cyst, which are most common extra-renal finding, pancreatic and splenic cyst, this is rarely symptomatic. Ovarian cyst in females also seen. Okay, so as we see, this ultrasound examination of 18-month-old male with autosomal dominant polycystic kidney disease. So you are able to see the large cyst. These are multiple large cysts, but corticomedullary differentiation is preserved versus autosomal recessive polycystic kidney disease. In those, small cysts are there and corticomedullary differentiation is lost. So this is difference between autosomal dominant PKD and autosomal recessive PKD. Okay, pathogenesis. Just to contrast, autosomal recessive polycystic kidney disease having PKHD1 mutation leading to fibrocystin gene. On the contrary, autosomal dominant polycystic kidney disease having two genes PKD1 and PKD2. The most common gene is PKD1. This is seen in 85%. Other PKD2 seen in 10 to 15%. Just remember the chromosome location also. PKD1 is chromosome 16 and PKD2 is chromosome 4. PKD1 polycystin 1 and PKD2 encodes polycystin 2. PKD1 associated with more severe renal disease, and the gene, the small amount gene is GANAB gene reported in PKD1 PKD2 negative genes. So this is very important slide. Just remember two gene, PKD1 and PKD2. Just remember chromosome 16, chromosome 4, polycystin 1 and polycystin 2. PKD1 is seen in 85% cases and associated with more severe renal disease. Other gene is GANAB. So this genetic genes of this autosomal dominant polycystic kidney disease are very much important. Okay, so how they work? Like polycystin 2, these disrupt the cytoprotein complexes and cyclic AMP signaling is involved, which promotes cyst growth and fluid secretion. It also reduces intracellular calcium, leading to abnormal proliferation cyst formation, and abnormal growth factor expression further drives cyst expansion. So in brief, what they does via cyclic AMP raising, decreased calcium and increased growth factor, all these leading to cyst enlargement. Okay, so this is important pathogenic mechanism of autosomal dominant polycystic kidney disease. Okay, what are the clinical manifestation? Generally in neonatal period it doesn't present or it is rare. What are the, if it presents, it generally mimics autosomal recessive polycystic kidney disease, gross or microscopic hematuria, bilateral flank pain, abdominal mass, hypertension, and recurrent urinary tract infection. So this generally mimic autosomal recessive polycystic kidney disease in that spectrum. Okay, so adult onset basically yes. So this is most common age presentation is fourth to fifth decade. Just imagine a disease which is actually originated in utero but presenting in adulthood life, that is also between 40 to 50 years. So this will provide a significant diagnostic challenge. So renal symptoms, progressive gradual kidney enlargement and cyst formation. Okay, so if you happen to do USG of that person, the kidneys will be enlarged and cyst will be there. Hypertension, it is early onset, often severe. If hypertension is early onset and severe, just do kidney ultrasound to rule out autosomal dominant polycystic kidney disease. Flank pain may occur. Some patient may present with flank pain as a first symptom. This is due to cyst rupture, hemorrhage into cyst, and nephrolithiasis. Proteinuria and progressive GFR decline are also seen. Extrarenal symptoms like liver cyst, they may give rise to hepatomegaly, intracranial aneurysm. Although they are seen in 15% of patients, but they cause significant mortality. That's why at 18 years of age, MRA is advised. Mitral valve prolapse seen in 12% of cases, aortic and coronary aneurysm and interstitial diverticulosis. Okay, how you will diagnose this condition? So basically, if you do renal ultrasound, you found bilateral renal cyst plus family history of autosomal dominant polycystic kidney disease. This is important. If we are not able to find this, then it may be a case of autosomal recessive polycystic kidney disease. But again, the ARPKD presents early and ADPKD presents late. Renal ultrasound findings are important. Multiple bilateral macrocyst. Just remember, in a recessive variant, microcysts are seen, but in dominant variant, macrocysts are seen. Early phases kidney may be normal. So genetic testing you can do in this PKD1, PKD2 genes are there. They confirm diagnosis in 85% of cases. So screening recommendation we are discussing. So asymptomatic children of affected parents, you have to do renal ultrasound. Family history of aneurysm, we have discussed earlier also. Consider MR angiography at 18 years of age, and prenatal diagnosis is also available. So what is the differential diagnosis? Just see tuberous sclerosis, VHL, glomerulocystic kidney disease, and multicystic dysplasia. So these are broad differential diagnosis of this condition. How you will treat or manage this condition? So the supportive care, blood pressure control with ACE inhibitors and ARB are drug of choice. Strict BP control, lifestyle modification in form of low sodium diet, moderate protein intake, avoid caffeine and smoking, and weight management. Pain management with NSAIDs and cyst decompression. So these are generally basically palliative or symptomatic management. Renal management is also symptomatic. If kidney stones are there, you have to work accordingly. For recurrent UTI, prompt antibiotic treatment and renal replacement therapy is required for end-stage kidney disease as the end result. So extra-renal manifestation, liver cyst, generally uh, keep them alone and just treat if their complication arises. Cerebral aneurysm screening you have to do at 18 years of age, and surgical intervention for large or symptomatic aneurysm. Cardiac monitoring you have to do echo because aortic aneurysm mitral valve prolapse is associated. And one drug that is very important, tolvaptan. What is tolvaptan? It is vasopressin V2. Just remember V2 receptor antagonist. It is not agonist. So tolvaptan is vasopressin V2 receptor antagonist. This actually slows cyst growth and renal impairment in adults. So this is very much important. Tolvaptan. This is vasopressin V2 receptor antagonist. This drug is very much important in initial consideration. So this was about autosomal meconium ileus. We'll discuss some another topic of this amazing series. Till then, do share, like, and